Good morning. I'm Mike Magavero. It's a real pleasure to, again, extend a welcome to everyone. Want to extend thanks to Ken. So Ken has really spearheaded this and really done a tremendous job, and Smith as well in organizing this. Other folks, Liz and Ryan, just tremendous support as well. All the speakers, it's amazing. You put out these requests for folks to come in and be speakers and workshop leaders, and the response was overwhelming. So thank you so much to all of you for coming in. And I think most importantly, all the folks that are here today to learn and share and kind of work together. So I think ultimately the success of today is going to be on these breakout sessions. So hearing these talks, but then coming together and sharing knowledge, learning together. And again, to me, this is a starting point. So today is not a one and done symposium, but hopefully a starting point for a larger dialogue, both at UAB, but outside of UAB. And seeing all those sponsors and all the folks here, I think that Ken is onto something, and we're onto something with this. A lot of folks are interested. It spans so many disciplines and centers. So really a tremendous opportunity for us to come together in a new way, and really exciting for this first step. So with that, it is such a great pleasure to introduce a dear friend, Rivet Amico, who is a research associate professor at University of Michigan. I've had the distinct pleasure of co-chairing the HIV Adherence Conference with Rivet for the last 3 years. So I've had a chance to introduce her in that setting to our larger HIV adherence audience. And it is such a pleasure to introduce her to our UAB community, because she is such a great asset. I've learned so much from Rivet over the years. And she's going to kick things off for us talking about conceptual models and behavioral frameworks in adherence research. I think in giving us this broad overarching background about how models and concepts fit in and shape the work and help guide interventions and evaluation. She is just tremendous, and such a thrill to have her here. So welcome, Rivet, and thank you for being here.
Woo, good morning. Again, my name is Rivet. I'm with the University of Michigan. I'm actually starting my timer so I do not go over time. I want to make sure that we all have an opportunity to have discussion. I have been researching in the area of adherence, particularly in terms of HIV, but in other areas as well, for the last 16 years. More recently, really focusing in on PrEP and pre-exposure prophylaxis adherence, retention and care as well. And I was really kind of challenged in putting this talk together because we could spend an entire semester talking about behavioral models, social behavioral models, systems models, social ecological models. And I really did try to do that at first in bringing this talk together. But given that we don't have a lifetime together, what I thought I would do is really focus in on something I feel very passionate about, which is why would you use any model in the first place? Because I think as we belly up to implement interventions, to improve our standard of care, to write grants for funding, we really need to have a sense of what's the purpose of having a model and how do we use it to our advantage and to the advantage of the outcomes of the interventions that are informed by the models. So with that in mind, I would like to have full disclosure that I would call myself a pragmatic interventionist. So I am typically not someone that comes to the table with a very comprehensive model in mind first. I tend to use needs analysis and looking at gaps and resources, and then going back to what are some concepts for me that I go back to a lot. But I tend to let the needs and the demands flavor how it is that I'm going to conceptualize things. That not everyone does it that way. So full disclosure on that front, and other full disclosure would be that I do have some unrestricted grants to create educational material for PrEP awareness. However, I have no conflict of interest with anything that I am presenting today. So in terms of an overview, I'd like to talk to you about why do we need social behavioral models. I'd like to give you a couple examples of social behavioral models. Again, just as example, not as a comprehensive overview of either of them or others, and then figuring out which model to use, because there's some nice ways to use things like needs assessment, intervention mapping, program evaluation to try to figure out what model to use, and some suggestions on how to use models productively in your work. So why do we need social behavioral models? And you guys have probably all seen this comic where, you know, there's some constellation of factors here, and then you see your outcomes over here, and then there's some miracle that happens in the middle that needs to be unpacked more. And I liken this a lot to what we're looking at with social behavioral models, or what the utility of them might be. is that we're often charged with marking, monitoring, and impacting health outcomes as indicators. And many of us implement strategies in order to do so, whether that's structural changes or changes in your own practice. Without a behavioral model or a social model or something that unpacks why this effort would be remotely helpful to this outcome, it remains a black box. And so in my belief, you need the social behavioral models to unpack that black box. And social behavioral models identify what factors influence the behaviors needed for outcomes to be achieved and sustained. And just to spend a couple moments on that. If your outcomes are ideal and optimal, you're not going to be spending much time, and there's not going to be, frankly, much interest in looking at unpacking the factors that lead to that outcome. If things are going well, you've got no variability to predict. You're not working on how do we do this better, right? But all of us here today are working in a situation where a substantial minority, if not a majority of people, are not having ideal outcomes. They're not able to execute adherence, for example, at optimal levels to achieve outcomes. And as soon as that becomes the case, we need to back up and ask the question of why, right? So why might that happen? And just as an example, this is antiretroviral adherence. We know that it's not optimal for a majority of cases, and we just heard a moment ago that that's the same really for a lot of conditions. Here we can see that it's estimated that about 70% of people taking fairly efficient, simplified regimens still are not reaching optimal adherence. And for HIV particularly, and I'm sure there's similar concerns for other regimens or other diseases that we're talking about, as an infectious disease, we know that if one is viremic, they have higher odds of transmission. We know if one is virally suppressed through taking their medications, they have very low odds of onward transmission. So it's not only an individual issue, it's also a public health issue. And again, here's just benchmark adherence rates across a number of different conditions. And you can see that some are estimated to be as low as 6.7%. To as high as 71%. So I think we're all in a pretty compelling position to be able to say that we need to be thinking about what is really driving adherence in these situations, and then what obviously might we be able to do to assist in that. Oops, I'm kind of going the wrong way. Oh. This, I don't think I need to say, adherence relates to outcomes. I mean, I'm pretty sure that we're all on that same page. Believe it or not, we were arguing this not too long ago of really having to make a case for how adherence behavior is critical. I think we've passed that corner, and people are well aware that adherence does indeed lead to outcomes, in this case HIV, but you have it across different conditions. So, to improve an outcome, you need to impact the behavior. And to impact the behavior, you need to impact the factors that drive the behavior. And that's what models do. They seek to identify what factors influence those behaviors. Social behavioral models elucidate the core pathways to the health behavior, and they try to do it with a degree of parsimony. And I would encourage all of us to do it with a degree of parsimony, because that's where they get very helpful and actionable. But it directs you to what you would want to intervene with and also why. So, for example, in the area of HIV, we look to increase the proportion of individuals that have viral suppression, or increase the duration of time that someone is virally suppressed. And we know that several behaviors are associated with that. For example, ART adherence, that's the regimen adherence, and also engagement in care, because we need to support persistence as well. And so that's our indicator, and these are our sets of causes. And so we have this, causal-ish pathway of ART adherence, engagement in care, and indicator. And oftentimes we will now jump straight to, okay, let's intervene to improve adherence, which you might have a lot of strategies in mind for how to do so, but we need to back up one step further. So one way of thinking of this is to move your causes and indicators back one step more. So what are the factors influencing behavior? What are the factors that are driving, underlying, facilitating, or deterring optimal adherence or optimal engagement in care? And that process becomes where you're really able to mobilize behavioral models. The behavioral models will help you to figure out what are those factors, and as well as give you proximal metrics for how are we doing with our intervention without necessarily having to wait for that distal outcome of failure. So in the absence of models, we have correlates, right? Almost all of our fields begin with correlates. Something's going wrong. It's not going as well as it was in the clinical trial, or the drugs aren't responding the way we want to. And there's this barrage of correlates, usually like demography. There you go. So a bunch of different independent factors are identified as, wow, it seems like less informed people this. It seems like homeless this. It seems like gender differences. And then you end up with a field that gives you good direction and sense of potential correlates, but it becomes very difficult to intervene when you have that kind of plethora of issues going on. And then top that off with the number of reasons you might hear, right? And this is all specific to adherence. I felt sick. I didn't want it. I didn't feel sick. I didn't need it. I was away. My routine changed. And so as you're trying to really think about what intervention do I want to do it straight from looking at correlates and straight from looking at reasons can become as chaotic as this room, and also as this slide. And so really the benefit of using these models is that it gives you a really parsimonious way to think about how these factors might influence the very outcomes that you're hoping to achieve with your patient populations. So we want to synthesize the complex causes of outcomes, behaviors, and influential factors. Now, every one of us sitting here has a causal model in their head somewhere for why it is that adherence is poor or good in your particular area. We don't always articulate what those models are, but humans are cause probing, we're cause seeking. There's no way for us to continually have exchanges with clients or patients without having developed some kind of working model in our head. The issue, though, is that we are also error prone. As human beings, we take shortcuts, we highlight certain events and discount other events. And so you have this huge benefit in being able to articulate the causal model. So be overt and identify what factors I think are going to be most influential. And why not use the vast literature where there's been a number of models proposed to really think about and maybe organize the factors that you're feeling are most influential for your particular outcomes and adherence. So I want to talk really briefly about some examples, and I also want to let you know that those people going to the behavioral model breakout, we made a cheat sheet for you guys. So we have like this pictorial. We have a lot of pictures of models that we wanted you to have because we knew we weren't going to be able to unpack them in the level of detail here. I want to focus in on a couple that you're probably familiar with. This is the health belief model. And here you have individual perceptions, you have perceived susceptibility, perceived severity, perceived threat or consequence of the disease, self-efficacy, and perceived benefits minus perceived barriers, all interacting and influencing each other to promote adoption or deter adoption of an outcome behavior. And that all happens in the context of cues to action, right? Because if you don't know you have an issue that you would like to deal with, or you don't know you have a condition, or you don't know what the regimen is actually asking you to do, that's going to be a difficult cue to action. But if you're cued to action, it's believed that these factors are critically important in long-term, short-term behavior. And then you can see modifying factors, which is almost this amorphous box over there on the side where it's like all influences, age, sex, ethnicity, education, personality, and knowledge kind of exist off to the side. So you should be able to very clearly appreciate the limitations of this in terms of, wow, all of society and environment is out over here. But a lot of the concepts that were identified in this model and subsequently used, not even subsequently, they're also used in many different models, is this idea of perceived susceptibility. And I'm sure you can resonate with this from your own experiences, that this seems to be important when people adopt a health behavior, is the belief about getting a condition. If I don't think that I'm vulnerable, if I don't think there's any chance of me getting this, then obviously I'm not going to adopt ways to prevent it. Perceived severity is just how bad would it be anyway? Some of the things that we were seeing in newly infected individuals with HIV as the treatments have become more and more simplified and efficient is, well, is it really so bad anyway? So a potential for the perceived severity of the disease to kind of wax and wane based on community beliefs as well. Perceived benefits. So what's the positive aspects of a health action? So what will I get if I do this? And then the barriers, which can be the negative parts of adopting the health behavior or the problems with not adopting it at all. Cues to action we talked about, and self-efficacy. Self-efficacy is the belief that you can actually implement a behavior successfully across different situations. And the reason I pull these out is that those of you who work with these models, you know you see these terms over and over and over again when you're talking about individual models. The other model I wanted to spend just a moment on, because it's a model I work from a lot in organizing my interventions, is the information, motivation, behavioral skills model. And in that model, the idea is that the ultimate adherence behavior obviously is what's needed for the health outcome. I mean, that's your distal goal here, is to get people highly adherent that will bring you the health outcomes that you're looking for. However, to do that, people need to feel well informed, and we might call this health literate, but certainly informed about the condition and why they would be doing it and how one should take their medications and what to do if there's side effects. So being knowledgeable about the regimen, but then also being motivated. And in this model, the idea of motivation is both personal. So what are my attitudes and beliefs about the positive and negative consequences of me adopting this behavior? And then also social motivation. So what are the positive and negative beliefs about the social consequences of adopting this behavior? And I can tell you that for highly stigmatized conditions, where people might not want to be disclosing their condition, the act of taking medication and being adherent and being retained in care can really tap into that social motivation in terms of it being a deterrent or a negative of pursuing these things. The thing I like about this model is that it's got some arrows to it. And not to say that the direction's always that way or that this is, absolutely veridical to the real world. But what I think is useful about it is that it does make some hypotheses. It says that you could have someone who's very well informed. You could have someone that is very highly motivated. But if they are not skilled, if they don't feel confident in their ability to actually implement the behaviors that they need to in order to be adherent, you're not likely to get high adherence. You could be really skilled. I could take medicine, no problem. I have no problem with that. But if I have no motivation to do so, I'm probably not going to be highly adherent. So what I like about this model is it offers some opportunities to think about the dynamics and the intersections between the constructs that are presented. My less loved part of it is the moderating factors affecting adherence. So there's this notion that let's say that you are acutely depressed, or you're an active drug user, or you are just got kicked out of your home, you're living on the street, you have a lot of instability. There's the idea that perhaps this model, would not be as effective in that context until those real severe kind of consequences or situations are resolved. In the work that I do, I find that most of the people I work with are exactly the people that would be living in the moderated box. So I've done some work looking at how could we situate this model. So this is obviously an individual model, right? It deals with you in front of you, beliefs, attitudes. And I wanted to bring in more of the social ecological pieces. So if we suggested we just call it a situated IMB model. And this looks at the same idea of like health literacy, of, social and personal attitudes and beliefs, as well as behavioral skills, but specifically those in the context of whatever that moderating factor is. So if I'm working with individuals who are really struggling with depression, I want to know what information is most activating to someone who's feeling really depressed. And if I'm working with people who inject drugs, I want to know what skills are needed specifically for people who have this, and this also competing with their skills of getting to care or using or taking medication. So the idea here is that with proper elicitation work, working with your target population, you can really elucidate what's the kind of information, motivation, and skills that's most relevant in this social ecological structure. So it's a way of trying to mold those two together, and obviously with a feedback loop. If I were to say the direction that our field is going, it is much more in terms of social ecological models. And the social ecological models, I think, are great organizational models right now, where they really can pull out what factors are influential from very micro, right, like physiological pathways, genetic constitutional factors, individual risks, social relationships, all the way out to far more distal or macro, like social and economic policies, institutions. And I think in the real world, this is a great snapshot of what it is to actually live your life, right? Because you are multiply influenced by many other factors, and you're influencing right back out from that. Where I would like to see this model go, I'm hoping the next step is going to be to talk about the dynamics between them. Right now, a lot of research and interventions are using this still as categorization. So we're going to intervene on the systems level here, and then we'll intervene on the individual level here. I'm looking forward to seeing approaches that actually try to think about the social will influence the individual in this way. So something that looks more at the dynamics rather than the separation between those lines. And I'm sure that's coming. Quick note on models and what they give you and what they don't. So the models that you use and identify for use are going to tell you the core concepts, the factors. What are the things that really seem to facilitate or deter the adoption of the behavior that you need someone to adopt to achieve the health outcome? What they're not going to tell you is how to do it. And so you need to be thinking about not only the explanatory model, but also the intervention model as well. So I might be using the IMB model and say, oh, motivation is really critically important. Great. How do I work with that? How do I increase motivation? Or how do I increase knowledge? So there's a two-step process in really doing a theory-based kind of intervention. One is really being clear on the model of causation, but then yoking that to models of intervention. And so models of interventions really are many, and we're not going to go over them, but maybe in the breakout sessions we'll certainly be able to talk about them. You've probably heard, I'm sure, of motivational interviewing, huge push for patient-centered discourse or patient-centered care. Problem solving is a kind of strategy that you might be able to yoke in to influence one of the core factors. Theater, arts, mobile health, and these are things that we try to use a lot with child and adolescent types of interventions. Community mobilization, couples counseling, family counseling, systems navigation, discrete navigation, peers. So, I mean, this list really goes on. And what I want to emphasize is that to really think about a comprehensive package of change, a package of intervention, you want to not only have a sense of what do you want to target, what do you want to change, but how are you going to do that? And then you can look at how it is that your implementations of interventions or changes really hits on any of those markers. So the hard part here is that there is no one model to use, and you guys know this. There's not one model in the literature that has come out as this is it, this is the model that explains all behavior. And even really successful models actually predict out to a fairly small proportion of variability in the outcome behavior at the end of the day. And here's my pragmatist perspective is that the models for me that I use are really helpful to the extent that they can help me to organize what is happening in my community, in my population, in my clinic, why that's happening, and how might we intervene. So one of the ways that I think is very useful to really narrow down and focus in on what model do I want to use, what constructs do I want to identify as the most important, is to do a needs assessment. And needs assessment either through continuous quality improvement strategies or intervention mapping approaches. And they can really be helpful to get a sense of where are the gaps, what bridges are needed, and how do I monitor this over time. And I'm sure you're all familiar with continuous quality improvement cycles. It's the plan, do, act, plan, do, check, act cycle, where you do need to start with a needs assessment. So what is the problem statement? What is going on? To learn as much as you can about, for example, why adherence is not where you want it to be. What are the gaps? What are the facilitators? And then develop a strategy around that, execute the strategy, review, refine, and manage. Now, in your classic literature like this, they don't really throw in theory or model. So I'm gonna. And where that would be is that if you think about where you're doing planning, right? Planning, you have to define the problem. You have to identify the root causes. Why start from the very beginning and reinvent the wheel every time? The better thing to do would be to go and look at what are the models that have been identified so far that really suggest what the core factors are going to be. So I would say as we identify root cause, we definitely want to be thinking about models of social behavior. Which model really fits the constellation of issues that we are hearing about from the work that we're doing during the planning. When you do, you need to be thinking about your intervention models, right? So just like we said, should I use MI? Should I use texting? Should I use phone calling or peer navigation? And those two need to make sense. If you use peer navigation, what is it about your particular model or your belief about what's driving a behavior that makes peer navigation the perfect fit? And then you want to look at, did the factors change, and you want to revisit the models. The other thing I want to just really quickly note on is that if you have a structural model or a model telling you, like, for example, I believe that self-efficacy is very important skills and information, it gives me some proximal things to measure. So as opposed to waiting to do the check and measure on, how many people are viremic, I can actually measure how many people have, enhanced medical trust, how many people have enhanced their information, how many people have, more positive beliefs and attitudes. It gives you a set of metrics that can be used to enhance your monitoring of the overall outcome and let you change things in real time before you've kind of waited until the end and realized something didn't work. Not going to explain this, but I want it in the slide deck because there's alternatives and there's continuing alternatives to the plan Do, Check, Act cycle. And this one is called the Knowledge V. And again, I'm not going to get into it, but I wanted to have it up there. Check it out. What's really interesting about that one is got a much more social more ethnography perspective of how we should be going through these processes. Intervention mapping, I just want to note quickly as another piece that can be used on its own or in consort with a implementation cycle. So here you would do a needs assessment, very similar to the needs assessment we were talking about before. What's going on? What seems to be the drivers? What are the gaps? What are the resources? Defining suitable program objectives. And I like this one because it actually does pull in theory and evidence-based. Because step 3 there is you select a theory-based intervention, methods, and practical strategies. So with that, you really do have to pull back, look in the literature, consult with experts, think about what it is that you think these causal proximal factors are and what might be good interventions with them. And then produce program components, materials, design an implementation plan, and an evaluation plan. So this is very similar to that cycle, but does draw a lot from theory. But again, it's a place that we would be able to yoke right in with intervention mapping right in that piece, which would then subsequently, obviously, influence all of the other pieces that go on. Program evaluation, not sure, we do it a lot in public health in terms of evaluating the strengths and needs of a program. And really it's logic, right? So when you come across, working with your population, working with your particular problem statement, that you really want to be looking at what's the outcome I want to work on, what's the gaps, goals, resources, models, right? So again, bring in the model to think about what's creating those gaps, and then that will become your proximal targets, and then use evidence-informed strategies to change factors influencing those outcomes. And it gives you ways to check in to see if the factors are changing. As I said, don't wait until the end. Really, you want to be monitoring throughout. And then you check for change in outcome. And all approaches suggest that once you have the outcome you want to address, once you know where there's variability, where you'd rather there not be variability and want to try to work on, you search evidence on behavioral factors influencing those outcomes. Remember those correlates and reasons? I mean, that's almost always the place that fields start. And then you identify evidence-informed strategies to change them. And when I say evidence, I think we're all really hardwired to want to go to like an evidence-based approach. Like this is clearly evidence-based. When you're talking about behavioral strategies and behavioral interventions and even structural interventions, just be cautious because you might not have an on-the-shelf intervention that works perfectly for your particular population, nor would I necessarily rule out ones that maybe didn't work so well and didn't make it to the shelf if it could arguably be appropriate for your population. So evidence includes literature, consultation, discussion with stakeholders, interviews in groups, a lot of elicitation, and listening sessions with community members and patients that are affected by the condition that you're talking about. And then really your experience should not be discounted at all. Remember we talked about you having internal working models. They're not random. They're usually developed out of a series of continuous exposures. So really drawing on your own experience can be very helpful as well. Ooh, I'm doing good. Okay, so how to use models in grants, proposals, and presentations. So here's my advice on this. Take what's helpful. I think you need to be very clear on your audience and your goal. What's the RFP? What's the foundation call? Like, but who are you talking to? And what are they wanting you to do? Because if you want to propose a model like this, that's fine. If it's an SEM kind of call for things. So if they're like, okay, we want to know everything that affects everything, that's exactly right for this. And in psychological methods, and in that division in APA, I mean, this is exactly what fills our journals, is these kinds of structural equation modeling. And it's really, the gear is to try to reduce or explain as much of the variability as possible in the outcomes. So you're going to throw everything in there. If I'm writing an intervention grant and that's the point of my grant, I probably am not going to include things like that because it'll be really hard to understand unless you happen to have a very exceptional group of reviewers. And also, anytime you have a figure on there, you need to be aware that you have to make a comment about it, that you have to develop a strategy around it, that it has to be something that's going to be utilized in your particular project, which is not to say don't be complex. You can be complex. I mean, this is something that you're not going to read in 2 seconds. You're really going to have to take it in and absorb it. So complexity is okay. But whatever you have, whatever pathway you decide to define, whatever constellation of impact you decide to define, reviewers are going to be looking for, why does that matter? How are you using that as you move forward in your intervention? So sometimes less is more. Sometimes it's not. But if you can do something that really kind of depicts, here's my working model of behavior, and I'm going to overlap it with the kind of intervention, because that's obviously what people are going to be looking for. If you think social support's important, how are you intervening? How will you monitor it? If you think beliefs are important, how are you intervening? How are you monitoring it? So whatever you put in that model, you really do have to have some kind of method of talking about it and not just kind of leaving it out there. I think also checking the literature. Obviously, you want to check it on the outcomes, but check it on the models that you're using too. You may do this. It's unlikely, but maybe you will come up with a brand new model that's never been proposed before. But consider that people have been proposing models for years and years and years and years and years. Whole careers spent proposing models. So what I would strongly recommend you do is look into the literature, and if you can find a model that's been tested in other areas that's close to the one that might speak to you, use an adapted version of it. Or create an all-new model, but I promise people are going to be a little bit more skeptical in reviewing that, and you'd have to spend more of your grant real estate time really building confidence as to why that's the right one to go with. Also check in on your intervention strategies as well, because remember we said that that's a whole other kind of dynamic field of literature. So if you're going to be using storytelling, make sure you dip into the literature in storytelling regardless as to what it's on, because you don't want to be proposing something that was recently reviewed as not effective, So just kind of keep that in mind. And again, I said this earlier, I'd be cautious about generalizability of what's available in the literature right now. So I would not rule out something that did not work elsewhere if you can make a logical, strong argument for why it would work in your particular patient population. And I wouldn't assume that something that was effective in one population is necessarily going to be effective in yours. I think that's a mistake that we make a lot, and that's where that elicitation and needs assessment research can come in very handy. Proposed metrics, again, so as you say that I want to intervene on social support, don't just wait until the end. Have some metrics that you're going to be looking at throughout the course of the implementation of that, so that you can see, is it changing, is it not changing? And really the bottom line is to know what leads to change in your outcome. That is the bottom line, is really having a strong sense of what are the pieces that are going into place that's changing this outcome that's important to me. And it's really important when you have null findings, because you may leverage this fabulous multi-arm intervention and you never articulated your theory. You never got down and said, hey, I think it's because it's going to affect how people think about their partners and how they feel about themselves. And you don't measure it. And at the end of the day, your intervention didn't work. But did it not work because it didn't increase those proximal variables, that it didn't, help people to have better partnerships, that it didn't help people to feel better about themselves? Or did it not work because it did increase those factors and it still didn't matter? in terms of the progression of science, the advice that you get from having a clear model and a clear way of unpacking intervention effects or non-effects, we move much faster in science when we're able to ask those questions and rule out those possibilities than to be like, oh, let's have a whole other 5-year grant cycle looking at that particular thing. And I think when you're in the area of infectious diseases and in deadly diseases where the longer we take, the more people die, we want to do our science tight the first time that we're doing it. So the other thing I just want to note, aside from just trying to really get you jacked up about unpacking a black box, is that in the breakout sessions, we are going to be talking much more about like specific models. I know I really stuck with an overview. I hope that you are thinking about, if not already using, the process models, because if you are, it's a really easy fit to bring in the behavioral and the intervention models into that. And even if you're not coming to that breakout, we can certainly get you a cheat sheet of it. So hopefully that was helpful, but I'll stop there. And I didn't know if we wanted to take questions.
Yeah, I think we have time, so thank you.